Good afternoon, ladies and gentlemen. Welcome to this new webinar from the European Menopause and Andropause Society. Today, our speaker is Dr. Iuliana Ceausu from Romania with the topic perimenopausal problems. And I would like to remind our attendees that you can ask questions to Dr. Ceausu using the question option that you have in your control panel, write in the question. And after the activities, we will read and Dr. Ceausu will answer. So please, Dr. Ceausu, when you want, you can start.
Thank you very much. Thank you very much to all the attendees of this webinar in this Halloween evening. And I hope that at the end of the presentation, the title Perimenopausal Problems will not be a problem, and attendees will understand that in menopause and perimenopause, normal problems, they may not may be assessed and maybe not problems. I have no disclosure regarding this presentation as I am an associate professor at the University of Bucharest at obstetrics and gynecology ward. And I will start with what we know, being an obstetrician and a gynecologist, that maybe the womb may be important than the home, as Professor Barker told us in 1970, showing that many problems in the adulthood health, many adulthood diseases are maybe have a programming in the uterine life. That's why I will start with a definition, the definition of menopause transition, because it starts somewhere in reproductive ages, and all this transition to menopause, the lifestyle and everything that happens in a woman's life may be related with problems in the later life after the menopause. Though the menopause, it's a normal period of life as it is a reproduction and birth and childhood and puberty and then aging. So menopause itself, it's not a disease and it is not a problem. Perimenopause should not be seen as a problem. As a background of my presentation, I choose the 10-point guide to the integral management of menopausal health. So the health in menopause can be assessed and by using a guideline which was published in Maturitas in February 2015 by the Menopause and Andropause Society. The first part is, of course, history and examination, and this is essential for a good assessment of the menopause health. And the medical doctor should start with the bothersome the woman came to the medical office and then assess the main important things in a woman's life and the signs and symptoms, family and personal history, including the breast, ovarian, endometrial and colon cancers. Also the personal risk associated with venous thromboembolism, which may be again associated with migraine, with different thromboembolic events during the life, or associated with other family pathologies in the venous thromboembolism status. The main risk factors for osteoporosis, heart disease, and stroke should be assessed, knowing the first cause of death a woman in postmenopause is heart disease and stroke. It should be recorded also the woman's preference about a treatment or another, the ongoing treatments. It is a while discussed nowadays in Europe, but mostly in the United States, about the physical exam of a woman. What is compulsory in a menopause assess consultation? It's to record the weight, the height, and this will be recorded at the BMI and the blood pressure. Sometimes, as it is during the pregnancy, the first correct recording of the blood pressure, which is taken in a menopause consultation, may reveal high values and may need further examination. Breast and pelvic examination, it is also compulsory. Even there are some doubts that routinely done may give tremendous benefits. As a gynecologist, I will underline the importance of pelvic examination, and it will be also underlined in the genitourinary syndrome assessment. About the mammograms, I have a very dear picture taken from JAMA, and we have as a clinical exam of the breast, the clinical window, the mammographic window, and the pre-mammographic window of opportunity to discover lumps in the breast. So a simple clinical assessment it is not reassuring of the absence of the disease at the breast level. So assessing the breast, it's assessing the risk. If it is any clinical disease should be discovered. Otherwise, the mammographic examination as a screening, a national screening in the absence of the risk, or an individual screening in the mammographic window or pre-mammographic window with other tools as MRI or other investigations should be assessed in women with individual high risk of breast cancer. At the consultation and investigation at the first menopausal consultation or at the routine consultation, the woman should be encouraged to participate in the national screening programs and to assess the individual risk or other neoplasia. Sometimes the new data the woman came at a routine consultation may change this plan. Surveillance for heart disease and stroke, and again for osteoporosis, are compulsory, and with all the ups and downs, pros and cons, it is still used and easy to use in the osteoporotic risk at a menopausal consultation. There are large studies done in Europe, and I will underline the Villa study done by Professor Ceausu in Sweden about the woman health, and they have 104 questions concerning assessment of menopause health, and also assessment of the lab test and other following other investigation in a woman's life. There is a Norwegian woman cohort study also having more than 100 questions, but the basis of a consultation, it is the giving enough time for the patient, giving the reassurance, being participative with the patient, and most of all, to take time at the first consultation to be able to assess the individual risk of a patient. In this case, it is a man, but also we should give the same assessment for the woman health in the menopause consultation, and to establish a program of investigation, personal risk, possible treatments for a person in menopause, because perimenopausal problems are not only for the patient but also for the doctor how to assess the health of a woman in menopause. And again, at this consultation, it should not be a problem to assess the menopausal status if there are present signs and symptoms which may be accompany maybe a sign of menopause, but also may accompany other health problems. The characteristic of menopause consultation is the woman usually come for hot flashes and should be assessed the menstruation status. Either they are irregular bleedings or absent menstruation in a woman over 45 or 50, especially with vasomotor systems and irregular absent menstruation. The diagnostic of menopause should be done easily. Assessment lab test with follicle stimulating hormone done in the first 5 days of the menstrual cycle. It's not compulsory to diagnose the menopause if there is cessation of menstruation of more than 1 year in a person with hot flashes or other symptoms, but it can be useful together with some other hormones, steroidian status for some population, or prolactin in investigating menstrual irregularity, or as you will see, also diagnosis of menopause when a woman is under contraceptive or hormonal treatment, or having an amenorrhea after the contraception, and in premature ovarian failure. Also, an amenorrheic person at 45 should be also investigated for a pregnancy. And the other lab test which should be done will be related to menstrual cycle disorder or irregular bleedings which are not conclusive for a menopausal status. So fashionable anti-Müllerian hormone, it's not compulsory, or better say, has a very little value in assessing the menopause as 50, because of course a woman has a poor ovarian reserve. It can be useful in a premature ovarian failure, mostly when a woman is addressing you for a fertility issue. Going further in our menopause consultation and in assessing the problems may appear in perimenopause, we are going to screen the diseases. There are many diseases that are associated with increase of age. Many diseases as neoplasia. So it's just a coincidence that the menopause is at 45, 50 years old, at the age when also starts the increase of personal risk for different neoplasia, and around 50s, again, the programs, the national screening programs for cervical, breast, and colon cancer are used in most of the countries. So the role of a menopause consultation for a woman between 40 and 50 is to assess the personal risk and see if a consultation and investigation for individual increased risk for cervical, breast, and colon cancer is needed. And we should not forget that if a woman has a mother or 3 cases of breast cancer on the maternal or immediate paternal side, it not be exactly a genetically inherited risk, but should be assessed with a mammogram in this earlier than 55 years before of the clinical disease was diagnosed in the relative, so in the mammographic windows. Osteoporosis, it's also related to menopause, but not exactly at early menopause. There are many other causes of osteoporosis, like lactation osteoporosis, like using of corticosteroids for other diseases as asthma. Prolonged immobilization also it's associated with the osteoporosis, though the individual risk and the lab test should be individualized in women with such a personal risk. Cardiovascular risk and 10-year risk of myocardial infarction according with Framingham studies should be assessed in every woman, and in this case also the cholesterol levels are advisable to be known at a woman in perimenopause and immediately menopausal status in the first 1 to 3 years, knowing that there is a window of opportunity in diagnosis and prevent the risk of atherosclerosis, accelerated atherosclerosis in a woman losing the estrogen protection of cardiovascular and vascular risk. This risk is very high for women with premature ovarian failure, and that's why assessment should be done in specialized center and in special cases. Going back to pelvic exam, which means a clinical exam and an ultrasound exam, vaginal ultrasound, it is advisable in asymptomatic women are again subjects, these 2 exams are again subject to a widely discussed from terms of usefulness and cost effectiveness in large asymptomatic population. As a gynecologist, I have no doubt that pelvic examination, and if it needs an ultrasound examination, mostly transvaginal, can be of capital importance in women and in discovering a special or assessing the health of a woman at the consultation at the beginning of menopause. And I will give you just an example of a fibroid in an asymptomatic woman, which does not mean anything in terms if it have a special dimension under 3, if it is not bleeding or if it is not increasing. It will be just recorded and it will be follow up if there are no problems. So assessing the pathology in asymptomatic women, it is important at least at the first menopausal consultation, and give value to our data for further follow-up in the menopause and to assess other pathologies. And again, another issue about the consultation, the cervical smear have an average of 41% in Europe. In Romania, just 8%. So according with the country and knowing the incidence of problems of the cervical cancer incidence and risk in an unfollow-up population, the clinical exam might be very important at the first consultation in menopause, as it is in Romania, where the cervical smear population attendance, it is just 8% comparing with other countries. So the situation should be assessed according also with the national um, rules and guidelines. Diet and lifestyle are very important, widely discussed, and many people are using the diet advices of the 7 Mediterranean or other low cholesterol diets, and increase the physical activity in menopause, which is a good advice, because recently it was published the result of the EPIC study, which show us the mortality reduction by diet and lifestyle changes in overall population, with assessing a large number of people. We know that all-cause mortality is a very, very compository um, um, risk factor to be assessed, but also this very clear data in a European population give us the importance of these changes, and the conclusion the study show that this will have a beneficial of the public health, means that in our consultation, at least an advice about the diet and lifestyle, cessation of smoking, and decrease the alcohol taking consumption, and increase the physical activity. It's important. Weight gain, it's one of the main problems in menopause, as a woman have a perception on it. The problem is not exactly the weight gain, it's what is gaining by this weight, and the disposition of this weight, which is usually in changing the body composition and increase the fat tissue, a fat tissue which is not hormonal achievable, and increase abdominal fat, which will further increase the cardiovascular risk. So again, the diet changes and lifestyle involvement by stop smoking, using diet rich in fiber, fruit and vegetables, and regularly exercise will help us to maintain a total body composition in a normal position, decrease the cholesterol levels, and to prevent further cardiovascular risk. Even a Cochrane review assessed the vasomotor menopausal systems, show that the diet and lifestyle has no influence on vasomotor symptoms. Even small studies show that they have some effects on vasomotor systems, or randomized control trials show no effectiveness on hot flashes and night sweats. Diet and lifestyle changes in menopause, mostly in reducing the bad habits as high cholesterol food intake, smoking, and alcohol intake, in lowering these habits, if they exist in an individual person, will help to reduce further the cardiovascular disease, even they will not decrease the symptomatology of menopause. Going further to hot flashes treatment, of course, the main treatment, the most effective treatment, is the menopausal hormone therapy. And if the hot flashes need treatment, it should be start early in menopause, and the benefits and the window of opportunity of menopausal hormonal treatment therapy to be highest effective with lower risk, it's in the first 10 years after menopause. The estrogen alone treatment is reserved to hysterectomized women because it needs no progesterone for endometrial protection. And the added of progestogens also increase the risk for cardiovascular disease and breast cancer disease, but they are needed to prevent endometrial hyperplasia and carcinoma in the woman with a uterus. There are large discussions about the estrogens and progestogens, which, how, and when. The estrogens therapy for menopausal symptoms, especially for hot flashes, they can be administered orally or transdermally. The progesterone also, the main route is orally, but also they can be given also locally with intrauterine devices or patches. Bioidentical hormone therapy is not recommended. The new treatment with bazadoxifan instead of progesterone in combination with estrogen give us new hopes in administering hormone replacement therapy also later in menopause, as it was recently discussed at an EMAS Congress in the United States. The Congress was recently finished. Tibolone is a well-known synthetic steroid, and it's a part of menopausal hormonal treatment, and it's very useful in the treatment of menopausal symptoms, having by its metabolic estrogenic, progestogenic, and androgenic action. The dose and time of menopausal hormone treatment should control the system, the minimal effective dose, and have less risk and side effects. The time they can be used, it is a discussion up to 5 years in the EMAS guidelines. Some may say 2 years, some may say 10 years. Anyhow, the individualization of the treatment may go as long as the woman it is symptomatic. After 5 years, they should be stopped, and to assess if the hot flashes are still present, they may reappear. Later hot flashes, resistant hot flashes, or very difficult to treat hot flashes are associated with an increased risk of cardiovascular disease, as we know from many studies of long duration. So the decision of continuing the treatment, it is on individual basis. Of course, we know that the administration of the estrogen on the transdermal route, it's lowering the risk both for venous thromboembolism and also for breast cancer, and also, as we learned from WHI study and from estrogen alone arm of this study, using of progesterone, of natural progesterone, it is compulsory to decrease the risk of breast cancer. It's advisable because the other progestin shows an increased risk of breast cancer in long-term users. Non-estrogen based therapy, they are less effective than the estrogen, and they will be applied in a person with contraindication of estrogen therapies. Paroxetine and fluoxetine hot flashes are effective on hot flashes, but they are very difficult to be used in women with tamoxifen or chemotherapy for breast cancer because they reduce the dosage effect of the required therapy. There are also venlafaxine and desvenlafaxine, very efficient in using in menopause. Also clonidine, gabapentin are useful when administered for severe hot flushes, and the curve of side effects and benefits should be assessed in these cases. There are also surgical um, therapies for alleviate hot flushes, which show different results in menopause women. Genitourinary syndrome of menopause, it's one of the most important issues should be addressed of the woman in menopause, early in menopause, but also later in menopause. And the term genitourinary syndrome of menopause was imposed as a terminology because it was needed for a more medical accuracy in defining all the terms describing the changes of the estrogen deprivation in the organs in the pelvic status, which means genital symptoms, sexual symptoms, and urinary symptoms, which were not included in the old terms of vaginal atrophy. Also, the genitourinary syndrome of menopause carry a very positive way of addressing these changes in the estrogen sensitivity tissues, because the old vulvovaginal atrophy or atrophic vaginitis, even they were described exactly the pathology at the vaginal wall and at the vaginal and of the lowering the secretion and sexual problems associated with menopause. It had a very negative connotation as a pathology. Also, the urinary symptoms which were prevalent were not included in this terminology, even they were present. So healthcare providers should address more actively in consultation these problems related to genitourinary symptoms, and also the term of atrophy and inflammatory problems as vaginitis should be avoided when these discussions are made in media further. In a recent study conducted by Nick Panay in London shows that more than 50 postmenopausal women suffer of genitourinary syndrome and vaginal symptoms related to estrogen deprivation, and they are very reluctant to discuss this in a clinical consultation, and that's why these genitourinary syndrome problems associated should be addressed directly by the practitioner in the consultation, because the quality of life can be spectacularly improved by simple treatments of this recognized syndrome in menopause. The treatments involve topical estrogen preparation with many forms. They are effective and the release should be achieved in time. That's why another very important advice when we prescribe a topical estrogen preparation should be say that the release will be in 1 or 2 months, and that's why one consultation after 3 months in seeing the results and assessing the quality of life achieved by the treatment, it is advisable. The treatment can be done with estradiol, with estriol, with promestrian, which is a particularly very good local replacement therapy, because the passage, even with a very atrophic vagina, the passage to the blood is very low. And now also conjugated estrogen can be applied in local preparation. It can be used alone or with systemic menopausal hormonal treatment. Even there is just one study which showed that menopausal hormonal treatment applied systemically by increasing the vascularization in the pelvis may first worsening the symptomatology in the pelvic floor and before alleviation of the system. That's why the topical estrogen is the first line in treating the genitourinary syndrome of menopause. It's no need for progesterone in the topical use of estrogen, and using of the estrogen treatment in women under the treatment for breast cancer, it is continuously debated. Anyhow, at the first line in this patient, the treatment should include hormonal lubricants and moisturizing creams. Ospemifene is the new treatment for genitourinary syndrome of menopause. It is an orally administered selective estrogen receptor modulator, and the indication of this drug in Europe, approved by EMEA, was to treat vulvovaginal atrophy in postmenopausal women who are not candidates for local vaginal estrogen therapy. In this way, the European Drug Administration showed us, underlined again, that the estrogen applied vaginally, it's the first line for this syndrome. And finally, I cannot underline again the importance of examination and assessing in urinary symptoms and vulvar changes by physical exam, and also by specific tests that may be done to assess the degree of atrophy and the need of care. And I have to say that also the EMAS published in 2013 a clinical guide about the vulva and lichen sclerosus, which can be very simple diagnose and treat after a consultation of a woman in menopause. So again, I have to underline that the consultation, clinical consultation in menopause, at least one, it is very important. Osteoporosis and skeleton and musculoskeletal health can be affected by different degrees of activities. The skeleton may be affected by osteoporosis, and musculoskeletal health deprivation. It is associated with sarcopenia, which may further lower and make very difficult the physical activity. That's why the prevention is important. Menopause hormonal treatment also, it is very efficient for preventing the osteoporosis, and estrogen therapy also have a windows of opportunity in the first 10 years of menopause. Non-estrogen based treatment for osteoporosis are also widely used. Actually, the bisphosphonates are widely prescribed drugs, the main treatment used worldwide. Also, denosumab, which is a human monoclonal antibody to the receptor activation of nuclear factor kappa B ligand, RUNKLE as it is the shortcut. It is also very useful, being a bone resorbing cytokine, and it is very easy to be administered every 6 months by an injection subcutaneously. Unfortunately, these two, even if it is not very frequent, they may be associated with osteonecrosis of jaw and atypical femoral fracture. That's why the follow-up should be very strict in administration of these drugs. SERMs as raloxifene and bazedoxifene, they are very useful and both reduce the risk of vertebral but not hip fracture. Unfortunately, they increase the risk of venothrombolism and hot flashes, and they are now recently used also in prevention of breast cancer in postmenopausal women. Mostly in the United States, the raloxifene is approved for this status. Strontium parathyroid hormone, it's restricted in some cases with women at high risk of fracture, mostly for vertebral fracture, but the treatment is limited to 2 years because of concern of other risks related to osteosarcoma, which were found in animal but not in human studies. And strontium raleate posed an increased risk of cardiovascular disease. The future treatments include cathepsin, new biological agents, and also strategies of administration, anti-resorptive treatments in preventing advances in osteoporosis. But the basic fact of preventing osteoporosis is the conserve muscular mass, to reduce falls, but advised by activities and advices of the diet and lifestyle changes, and also to administrate vitamin D, which also preserve the tonus of the muscles and may give protection for bone loss. Premature ovarian failure, I will shortly, because the time is running so quickly. It is a specific status, early menopause, and it's associated with increased risk of osteoporosis, cardiovascular disease, dementia, cognitive decline, and Parkinson if it is not treated. The treatment should continue at the till the menopause age, and it can be used with contraceptive and menopause hormonal treatment. It is advisable to be used with menopausal hormonal treatment, and it was shown that it is not an increase of breast cancer and other neoplasia. Ovulation may occur intermittently, but the diagnosis, it is not infirm if it is an ovulation occurred during this period. And non-estrogen based treatment for osteoporosis in women with premature ovarian failure. There are no data about this, and also we don't know the side effects if the pregnancy occurs. Contraception in the perimenopause, do we need? Yes, we need. We need because the fertility decline, but the sterility cannot be assumed even later in life. The spontaneous pregnancies, they may occur till 50, but we cannot count on this if a woman may come with a fertility problem. It's very important because of the risk may carry by administrated contraceptive, and the contraceptive, there is no contraindication of the contraceptive alone just because of the age. There are some rules, so if age 50 or more, just one more year after the final menstrual period. If under 50, can be used 2 more years. There are different types of contraception, sequential contracepting or intrauterine levonorgestrel carrying, which may pose problems to diagnose the menopause. And in this case, the FSH levels should be used. All contraceptive can be used in women without cardiovascular or thrombotic risk factors in the perimenopause period, but the second generation are the best. They can be used barrier methods, withdrawal, other local contraceptive like Cooper IUD or levonorgestrel IUDs, and they can be very effective. They are permanent contraceptive methods which can be proposed to the couples in perimenopause problems, tubal ligation, hysteroscopical tubal occlusion, vasectomy, which can be proposed in menopause, and it is widely used in United States, but also can be used worldwide. Yes, there is still need of contraception in perimenopause, and advantages of the contraception treatment should overweigh the risk, and to be used mostly the local one or barrier methods should be proposed, and you should be in favor of this local acting contraceptive. Contraception can be stopped once the menopause is installed. When it is menopause installed in a woman with under contraceptive, there are some small rules. It's difficult to assess exactly, but FSH in this situation measured in 2 occasions with 6-8 weeks apart, it can be used. The follow-up, yes, depends of the woman individual risk and mostly about the medication she's taking. There are guidelines that shows that no routine follow-up is required, but if the patient addresses with new issues, she should be encouraged to come to the doctor. Reassurance make our life a little bit pink, and reassurance and regarding the menopausal health, which is a health period. It is a normal period of a woman's life. Even the age may pose risk as osteoporosis, cardiovascular, or genitourinary symptoms may appear and relapse during and after the hormonal treatment cessation. The menopause hormonal treatment follow-up requires at least 1 annual consultation, assessment after the prescription between 3 and 6 months according to the prescription, and also at any time the balance between benefits and risk need to be assessed. In women with premature ovarian failure, this visit should be more frequent, 1 year according with the age, and the problems may account in under the treatment and when the treatment is stopped. The follow-up of mammographic and cervical smear, according with the national guidelines, should be done in a proper rhythm, and the treatment for osteoporosis also needs follow-up and assessing the balance between benefits and risk. Quality of life in menopause, it is important. And quality of life is often regarded as how it negatively affects on an individual level the health and the perception of health, debilitating weakness that is not life-threatening, life-threatening illness that is not terminal. So in menopause, assessing the quality of life, it is very important for the general well-being and for the happiness. Even if we are not doing the assessment of our happiness in menopausal subject, because it's very difficult to measure, the menopause consultation should underline that menopause it's a normal period of life, as it was the birth, as it was the pregnancy, because also in pregnancy there is a weight gain and there are other risks that should be assessed. And we hope that we will see you in Amsterdam next year to to convince you that menopause it's not a problem, not for the patient, not for the doctors, if it is properly assessed. Thank you.
Thank you very much, Dr. Ceausu, for a great presentation, very complete. And now we continue with our next activity for this webinar from the European Menopause and Andropause Society with our polls. So I will explain briefly. Dialogue will appear on your screen and with multiple choices, and only one will be the correct one. So here you have the next one. Here we have the results from our first question today. The first consultation in menopause clinic should be option A, very short, no news to discover. It was chosen by 8% of our attendees. Option B, 15 minutes as a control. It was chosen by 8% of our attendees. Option C, 30, 40 till 1 hour for anamnesis and consultation. It was chosen by 85% of our attendees. And option D and E, there were no choices. In this case, the correct answer, it was the option C, 30, 40 till 1 hour for anamnesis and consultation. So we continue with our next question. Here are the results for our second question today. Signs and symptoms of menopausal syndrome are option A, hot flashes. It was 6% of the answers. No answers for the option B and C. For the option D, all of above is chosen by 56% of our attendees. And the option E, answers 1 and 3, it was chosen by 38% of our attendees. In this case, the correct answer, it was the option D, all of above. So we continue with our last question today. Here are the results for our third question today. How should be the perception of the woman about the menopausal status after the first consultation in menopause? There were no answers for the option A. 11% answered the option B. Menopause means just the end of the menstrual bleeding. 89% answered the option C. Menopause is a psychological part of the woman's life, and no answers for the option D and E. In this case, the correct answer is the option C. So we continue with our next activity. As we mentioned at the beginning, our attendees had the possibility to write the questions for Dr. Ceausu, and she will answer now at the end of this webinar. So I'm going to read the questions, and Dr. Ceausu will answer by voice. So the first question is coming from Stephen Nordin. Are hot flashes more prevalent at specific times of the day? Please, Dr. Ceausu, your answer.
The hot flashes at the beginning of the menopause, they are described mostly during the night. So the woman at least complain of hot flashes mostly during the night when she's resting in the bed, and they may be associated with night sweat, specifically located on the back of the head, and also with sleep disturbances. Further, when the deprivation of estrogen is higher, they should be present also during the day, and recording of hot flashing, everyday hot flashing, the hour and the intensity may have a chart which give the severity of the hot flashes and how the woman quality of life is impacted, and support the necessity of an intervention, of a treatment.
Thank you very much, Dr. Ceausu, for the answer. We have another question also from Stephen Nordin. How common is it for hot flashes to continue post-menopausally?
Hot flashes after it, there are described two main types of hot flashes, early and late in menopause. So then they carried a little bit a different of risk. So the early hot flashes, they are mainly done by estrogen deprivation, and they affect, they are the most prevalent symptoms of menopause, and the woman addressed to the doctor for these early hot flashes, and they may be alleviated by the hormonal treatment. Mostly by the hormone, but also by the non-hormonal treatment in case of the risk. Late hot flashes or persisting hot flashes under the treatment late, means even they started after 10, 20 years after the menopause. They were associated mostly with a high risk of cardiovascular disease. They also must be investigated for other causes of flushing, like other carcinoid syndromes, and they should follow up the regular tree of diagnosis for hot flashes, and they also can be alleviated with treatment. The recent data showed by Pinkerton and presented some days ago at the EMAS showed the hormonal treatment for these hot flashes. They are useful regardless of the age. Till now, we have reluctant to give after the WHI, so we are reluctant to give hormonal treatment in late menopause, but we will see. Stay in touch, and in Amsterdam, maybe I will give you another answer about the late hot flashes.
Thank you very much. We continue with our next question from Basilios Nikas. Does the intensity of hot flashes correlates with increased cardiovascular risk? Please, doctor.
Usually the severity of hot flashes is also associated with persistent and resistant to the treatment, and these are associated with an increased risk of cardiovascular disease. So the direct associating between the severity, it is not as direct, but by persistent and time of occurrence according with time since menopause, which is another concept in assessing the health of a menopausal woman. So times since menopause.
Thank you very much for your answer. We have also greetings from Rebecca Glasser about the excellent presentation. Thank you. Thank you, Rebecca, for being with us today. And we have our last question today. It's coming from Napoleon Paredes, and it's related with what is your opinion about the phytoestrogens? Please, Professor, when you want.
I think that phytoestrogens, that they are now on the market as a medication over the counter. It is widely used, and it is more and more used also in the United States as they were started in Europe. I think that the phytoestrogen have a place in treating menopausal women after the assessment of the menopausal health, because the dose efficiency, it is not very let's say has done with accuracy in this treatment. So administration of estrogen even in a diet as a phytoestrogen may alleviate the symptoms but will not decrease the risk. So I think that phytoestrogen has an effect on menopausal symptoms, but we need more studies to also quantify the risk when administered one or another form of phytoestrogens.
Thank you very much, Doctor, for your answers. Thank you very much, our attendees, for your questions and for being with us today. And I would like to remind that this webinar is being recorded, so the members of the EMAS Society will have be able in few days in your personal space. And the attendees that are not members, we invite you to become member and to visit our website, www.emas-online.org, and become a member. And also you have another possibility, that is to ask for a 3-month trial membership. And for us, it would be an honor to have you with us. So once again, from the European Menopause and Andropause Society, we appreciate so much that you attend today to this webinar, and also we will be very delighted to see you the next May in our 11th European Congress on Menopause and Andropause that will be in Amsterdam. And wishing you a very good day, and to see you next time. Thank you very much.